I'm Catherine.
I'm Sophie.
I'm Ashley.
And today we're talking about a case study from the New England Medical Journal titled A 26-Year-Old Pregnant Woman with Ventricular Tachycardia and Shock. So to start with the presentation of the case, the patient is 32 weeks pregnant with twins. She has gestational diabetes, but previously had 2 healthy pregnancies. She actually came to the hospital because of edema of her right leg or swelling that had been increasing in pain. So she came to the hospital with that pain, but by the time she was actually seen by a doctor, she had gone into labor. She was having contractions and she was 2 centimeters dilated. The doctors did everything they could to prevent this preterm labor as well as prepare for if it was inevitable, but they were able to stop the contractions and actually treat her swelling of her leg. They found that the cause was a thrombus in her left perineal vein, which is just a blood clot. And so they were able to treat that with some anticoagulants. And then they put her on bed rest because they thought preterm labor was possibly a risk. So she was on bed rest at this point for 5 days, and on day 6, the patient went into cardiac arrest. She had sudden severe crushing chest pain and became unresponsive and pulseless. Luckily, they were able to revive her after 4 minutes, but they had to intubate her to assist with her breathing. They gave her some pain medication for this, but they also had to initiate an emergency C-section. Luckily, both babies were born healthily, but the patient was in critical condition with a low blood pressure and a high heart rate of, I believe, 173 at this point, with an irregular heart rhythm.
"210 minutes after her cardiac arrest, the patient arrived at a second hospital for treatment. At this point, her heart rate was 177 beats per minute, and she had coarse breath sounds and generalized edema. The patient was cannulated, which involves the placement of a catheter in a blood vessel, in this case her aorta, to start extracorporeal membrane oxygenation, or ECMO. ECMO is the most invasive form of life support that we have, and it allows the heart and lungs to rest. At this point, her arrhythmia due to ventricular tachycardia returned, and it was cured with cardioversion, which is a series of slow and low-energy shocks. The patient was then transported to a third hospital." I also feel like...
Okay. Sorry. So a CT scan was performed at the first hospital to look at the blood vessels and the organs in the patient's chest to see what was going on, and contrast was used as well. So on the left, in A, you can see that there are bilateral patchy ground glass opacities, which are indicative of fluid or swelling, partially blocking the air spaces in her lungs, as the patient did have wheezing. There's also interlobular septal thickening, which is consistent with pulmonary edema or dilated vasculature of the pulmonary veins and an enlarged heart. And then in B, you can see the arrows at the bottom point to bilateral pleural effusions, which are indicative of cardiomyopathy. These small bilateral pleural effusions are accumulations of fluid in the pleural space and are indicative of both heart and lung damage. And then at the top, you can see the cardiomegaly, which is a swollen or enlarged heart, and there is biventricular enlargement and thickening of both heart walls.
At this point, they transferred the patient to a third hospital in a helicopter, which is usually a critical transportation. And the patient began bleeding vaginally, and clots were observed. And they treated this blood loss with blood transfusions as well as an intrauterine balloon to try to staunch the bleeding. In the positive, the patient was able to be weaned off her pain medication and was responsive to commands. And her vitals were more stable than previously, with a heart rate of 123 and still a low blood pressure given her blood loss of 76. So the patient's still in critical condition, but slightly improved from right after her cardiac arrest. So moving in the right direction.
So upon arrival at this third hospital, an ECG was performed, an electrocardiogram, which records the electrical signals of the heart. The ECG shows a normal sinus rhythm, but a right bundle branch block, borderline low QRS voltage, and Q waves with T wave inversions in the anterior and lateral leads. In normal cardiac conduction, impulses travel equally down the left and right bundles, with the septum activated from left to right and formation of small Q waves in the lateral leads. However, our patient has a right bundle branch block, so when the signal goes down the right bundle branch, it is slower than the left, and the right ventricle contracts later. This results in a delayed activation of the right ventricle and production of a secondary R wave and a wide slurred S wave in the lateral leads. So in V1 and V2, highlighted on the board, there is T wave inversion. You can also see that the R wave is bigger in V2. V2 and V5, you can see the low QRS voltage, and then in V5, you can see the slurred S wave. In addition to the ECG, a TTE was performed, known as a transthoracic echocardiography. This uses ultrasound waves to create images of the heart to see all 4 chambers, 4 valves, and the blood vessels nearby. So in the bottom area, you can see that the patient has a dilated left ventricular cavity and severe left ventricular hypokinesis or decreased range of motion, which is indicative often of a myocardial infarction. The patient currently has an estimated ejection fraction of 11%, with normal being 50% or above, and anything below 40% can be indicative of heart failure because your heart is not pumping enough blood.
And her percentage is what?
11. And then at the top arrow, you can see small pericardial effusion, which is the excess fluid in the heart.
So ventricular tachycardia is the irregularly fast pumping of one or both ventricles that causes an irregular heart rhythm and inadequate blood flow to the body. Cardiomyopathy is a disease of the heart that also causes inadequate blood flow to the body. The patient has had both of these conditions, but the question is which caused the other. While a new arrhythmia can be common during pregnancy, it typically is not from the ventricles, or if it is, it's from the right ventricular outflow, and our patient's is from the left. Additionally, this patient had a higher heart rate at a prior hospital visit that suggests an underlying heart condition. She also had marked dilation of her cardiac chambers, and all 3 of these points point to pre-existing cardiomyopathy.
Looking at our laboratory data, the 2 most important aspects we thought were her troponin T levels and her creatine kinase and B levels, because both of these are indicative in high levels of structural damage to the heart. And especially her troponin T levels, you can see that the reference range is 0.03 and her range is 28.32. So definitely high levels of these proteins, which just further support structural damage to the heart. Question? Oh, no. Yeah. No.
Okay, so the next step was differential diagnosis. So after ruling that the cardiomyopathy preceded the ventricular tachycardia, the doctors ruled out a couple different types of cardiomyopathy based on the patient's history and the lab results that Catherine just talked about. They ruled out neuromuscular abnormalities, genetic diseases, alcohol and drug use disorders, and nutritional and endocrine disorders. At first, an amniotic fluid embolism was considered, but subsequently ruled out because the patient's sequence of events leading up to her cardiovascular collapse were not consistent with this embolus. So the patient had preterm labor, which an amniotic fluid embolism usually occurs during or immediately after labor, and is associated with a disseminated intravascular coagulation, which the patient did not have. This left the doctors with 3 possible causes of the patient's cardiomyopathy. The first, peripartum cardiomyopathy, characterized by a left ventricular ejection fraction less than 45%, which the patient did have, but most often occurs towards the end of pregnancy and or in the months after, but usually does not happen before 36 weeks of gestation. A twin pregnancy is also a predisposing factor, but she had no other risk factors like black race, advanced maternal age, preeclampsia, or traditional cardiovascular risk factors. However, doctors left it as a possibility. The next considered was myocarditis, which is an inflammatory disease of the myocardium that causes dysfunction. The presentation is variable and can range in symptoms from fatigue and dyspnea to cardiac shock and death. The patient's presentation is consistent with myocarditis due to her elevated troponin T levels, her chest pain, and her antecedent illness. Lastly, it was considered that it could be pregnancy-associated myocardial infarction, which is becoming increasingly recognized as it occurs in 9.5 per 100,000 hospitalizations of pregnant women. The leading cause of pregnancy-associated myocardial infarction is a pregnancy is a spontaneous coronary artery dissection, followed by atherosclerosis or coronary thrombosis. The presence of a coronary thrombus is likely due to the patient's presentation. Although the presentation of a spontaneous coronary artery dissection is often to be more severe, it is associated with the reduced ejection fraction, multivessel coronary artery involvement, and ST segment elevation. The patient does present with these high-risk features and thus a pregnancy-associated myocardial infarction, possibly due to a coronary artery dissection, is a possible diagnosis. And then looking back at the lab data, in order to narrow down the diagnosis even more, the increased troponin T levels narrowed it down to myocarditis or pregnancy-associated myocardial infarction. And then the next step was to perform a coronary angiography to make the proper diagnosis. So this looks at how the blood flows through the arteries in the heart, and as you can see, based on the arrows, the patient had a spontaneous coronary artery dissection indicated by the fact that the distal arteries, further ones away, are much larger in diameter than the more proximal arteries, which are much thinner. This led the doctors to a primary anatomical diagnosis of a pregnancy-associated myocardial infarction, possibly due to spontaneous coronary artery dissection of the left main territory.
At this point, the plan to manage the patient's condition was to maintain her on ECMO at a rate of 5 liters of blood moved per minute. But ECMO placement in the aorta can create a retrograde flow to the left ventricle that increases left ventricular afterload. And there was no outflow observed from this patient's aortic valve, which suggests that her left ventricle was really struggling on this treatment. The treatment for this was to place an LVAD, or a left ventricular assist device, that creates a forward flow from the left ventricle to the aorta. After 7 days on the LVAD with no improvement of the left ventricle, the patient had ECMO and the LVAD removed and a permanent LVAD was placed. At this point, the patient was discharged 35 days after hospital admission on a neurohormonal blockade to maintain cardiac homeostasis, warfarin and aspirin to prevent thrombosis or clotting, on an LVAD, and as a candidate for heart transplant. 9 months after discharge, the patient was readmitted for cola-colored urine due to hemolysis or red blood cell death, and was diagnosed with LVAD thrombosis, which is the clot in the LVAD. The only treatment for this was to just replace the LVAD. After a full year on the LVAD, the patient accepted a heart from a hepatitis C positive donor to expedite her transplant process. She left the hospital after a successful transplant on a typical immunosuppressant regimen plus an 8-week course of meds to treat the hepatitis C. After the 8 weeks were up, the patient had an undetectable viral load of hepatitis C, and 2.5 years later, her heart was still healthy.
A whirlwind.